So today I'm going to be speaking about the placement, removal, and management of enteral feeding tubes. I have nothing to disclose. The objectives, so by the end of this, you should be able to assess various types of enteral feeding tubes, similarities and differences in the placement of tubes. You should be able to discuss the management of feeding tubes, specifically recommendations for unclogging them, and then describe the safe administration of tube feeding modulars, etc., through a feeding tube. And then we'll be able to discuss how and when to safely remove a feeding tube. I just realized I didn't start my timer, so do that right. All right. So throughout this presentation, we'll look at the placement of feeding tubes. So we're going to compare nasoenteric versus G-tube and PEGs, the modes of placement, and how to confirm that it's in the appropriate place, and then the management of feeding tubes, so clogging, dislodgement, and different things to maintain, and then the removal of feeding tubes of both types. So we'll start with the nasoenteric nasogastric tubes. So these can be placed in various different ways. So nurses will a lot of times place NG tubes at the bedside. They'll also place NJ tubes at the bedside. Also under direct visualization or indirect visualization in real time. These must be verified in pretty much every hospital by either chest X-ray, ultrasound, or electromagnetic placement devices. So like if you have the device where you put the thing on your chest and then you kind of watch as the tube goes down, or a camera itself, so like in endoscopy. They can be placed in IR, or they can be placed in surgery. So a lot of times when the nurses place feeding tubes at the bedside, they don't get the feeding tube placed right away. So sometimes it can go into the lungs, sometimes if they're trying to go post-pyloric, it can just go into the stomach. So I know at least at Piedmont, the rule was if you can't place the tube where it should be within 3 times, the patient has to go to IR or interventional radiology to have the tube placed. And then a lot of my experience with DOPHOF was when they would come out of a surgery and they would have the tubes placed during surgery. And then of course the surgeon can pull the tube into the appropriate location. So this is different pictures of how the feeding tubes are placed. So the first one here, and I should have made this quiz, but I didn't. So the first picture in A, the tubes in the right lower bronchus, so it went to the trachea instead of the esophagus. So you can see how it diverted immediately to the left as opposed to going down a little bit further. In the second picture, the tube is in the descending limb of the duodenum, so you can see, I don't know how well you can actually see it, but it crosses over the spinal cord and then over to the right, and then kind of goes back over the left, and then kind of goes back over the right. So you can almost want to see it cross 3 times when you're confirming that it's actually in the duodenum, say if you're looking at a KUB. The third picture is in the cervical esophagus, and then in the fourth picture, it's in the distal esophagus. So I know that some of these may look like they're in the same place, but it's just in different places on the chest too. So this is via electromagnetic placement device. So these are actually the same picture kind of. So this is what you would see on a device at the bedside. So this is if the patient is having it placed at the bedside without getting confirmation or needing confirmation from an X-ray. So on the left, this is what it looks like on the placement device. So you always want it to be below the center of the axis. If it's above that middle line, then it would be in the lung. Or if it's above, I don't know if it's above or below. And then to the right, you can see that it kind of takes the same trajectory, goes up a little bit, then goes back down and crosses again. Aspen luckily has a bedside feeding tube placement tool checklist. Just quick show of hands. Do any of y'all place feeding tubes, or have you ever? Okay, perfect. And so I know it's not something that's super common for dietitians. I know nurses are usually the ones who do it, but I feel like nowadays with nutrition support teams, it is something that's becoming more common. So luckily, again, Aspen has this lovely checklist to kind of streamline everything and make sure you check off everything. So after a feeding tube is placed, we definitely want to make sure that it is secure in place, or else it can migrate up. So a lot of times previously, doctors, nurses would use tape to secure it. That's, to me, not the best way to do it, because the patient can remove the tape. In surgery, they'll usually use sutures to put it in place, or a nasal bridle. That's becoming more common now. When should you not place an enteric tube, a nasoenteric tube? So if the patient has esophageal varices or any esophageal disturbance where the placement could cause harm, bleeding, anything like that, then of course you don't want to place the tube. If they have coagulation issues, if they're hemodynamically unstable, or if they've had Roux-en-Y surgery, or if they've had a post-gastrectomy, or they've had gastrectomy or a Whipple, if you place a tube and you're going into the pylorus, then a lot of times it can affect the anastomosis and cause bleeding. So once that tube comes out, if it's been placed after a surgery, then it can't be replaced. That's why those securing devices are good. So placement of GJ tubes and PEG tubes. So one thing that I always asked was, what is the difference? The difference in the two is about how they're placed. So and when they're placed. So a PEG is placed in endoscopy, a G tube is placed during surgery. They're the same. So the PEG tube, it's best in the setting of esophageal obstruction or a need for post-pyloric placement. Basically an endoscope is passed into the mouth, down the esophagus, into the stomach, and then an endoscope is used to visualize and watch as the feeding tube passes through the small incision in the skin of the abdomen and into the stomach. And then a balloon holds the tube in place. The G tube is surgically placed, either laparoscopic or open. A small incision is made on the abdomen, and then an opening is made in the stomach, and then an external bumper holds it in place. So management of feeding tubes. So for GJ tubes, you always want to make sure that you're cleaning the tube with soap and water, letting the patients know to do this at least once a day. They always want to use it, having a clean environment when flushing, use aseptic technique when handling the feeding tubes, formula, or administration set. So washing hands really well, making sure it's in a clean area. Tube clogging is definitely an issue that I dealt a lot with at Piedmont and with a lot of patients in surgical oncology. And tube clogging can happen for lots of different reasons. It could be that it's a really narrow tube, like a dog hop tube, which is really, really small. Could have to do with tube location, maybe not enough water flushes in frequency or in the volume that is actually administered. Or faulty medication preparation or administration. So say a medication isn't crushed up enough, which Alex is going to talk about later. That can also cause issues with clogging, and then gastric residual checks can actually cause issues and cause clogging as well. So to avoid clogging, you want to make sure you flush with at least 30 milliliters of water every 4 hours, and each time the tube feeding is held or stopped. Medication should be administered in liquid form or dissolved in liquid. I always recommend avoiding blenderized tube feeding formulas through a J tube because it is smaller, unless it's diluted more with water. And then avoid gastric residual checks, as the stomach acid can cause protein in the tube feeding formulas to precipitate in the lumen of the feeding tube. So generally, if a tube gets clogged, the nurse or the dietitian or whoever will flush with warm water at first, and then most hospitals nowadays have an enzymatic declogging kit, but we started to notice that a lot of times those didn't really work that well. So at Piedmont, I actually developed a protocol for unclogging the feeding tubes through a little bit of trial and error. I'm sure a lot of you have heard about, how to use enzymes to unclog the feeding tubes, but we never really had it in practice. It was more so like, oh, try this, and didn't really have a step-by-step. So this is something that we developed. And so I'm going to go through these because this is just something that I came up with as far as like the timing and everything. It's more of just a recommendation, and it worked for my patients every single time. So we would take one pancreatic enzyme capsule, crush it up, mix it with half a teaspoon of baking soda, or if you're in the hospital and you order from the pharmacy, the sodium bicarb tablet, that works as well. Get a large syringe. We used cap tip, and then a graduated cylinder, a clog set or a clogged zapper set, and then towels and a small cup. Crush the enzymes into a small powder, crush the sodium bicarb into small powder, or use baking soda. Fill up a cup with 30 milliliters of warm water, put the enzyme mixture in there. Then, of course, you introduce yourself to the patient, let them know what you're doing, make sure you have your towels and stuff around, because it does get kind of messy if there's a clog. If you push too hard, a lot of it's going to come back at you. So what I try to do is flush the feeding tube one more time with warm water, because sometimes like the nurses have been kind of maneuvering it a little bit, and maybe they actually got it a little bit unclogged in the time frame that it took for them to come and get you. And so flush it one more time. If it doesn't work, then you want to get all of the residual contents out of the feeding tube. So kind of squeezing the tube a little bit onto a washcloth. And then what I did was I would take the stylet from a clog buster kit, insert it into usually it was the J tubes that got clogged, G tubes pretty rarely, but put it into the J port, and then try to use that stylet to break up the clog a little bit. And if you can, insert the stylet all the way in, kind of maneuvering it in as you can. And then usually there's, depending on which clog device you're using, either cap tip or lure lock or infit, to screw on the syringe. So what I would do is I would fill it up with 15 to 20 milliliters, depending on how much would fit in there, of the enzyme mixture, and then infuse it through that teeny tiny stylet. So that way it's getting to the clog and not just kind of sitting at the front of the feeding tube. And then I would leave it in for 1 to 2 hours so that it can dwell in there and break apart the clog. And then after 1 to 2 hours, try to infuse more of the enzyme through the stylet and then remove the stylet. Then I would use the syringe to flush the enzyme mixture one more time through the feeding tube. If it doesn't work, then I would leave the enzyme mixture just sitting in there without the stylet for 2 to 3 hours. After 2 to 3 hours, I would try flushing again with warm water, and it does need to be warm water, not like scalding hot water, not room temperature, it needs to be warm. And then gently pump the syringe back and forth, because if you try to push it really hard, sometimes it can actually pop the tube, or the water and gastric residuals can come back in your face. So anyway, so push it back and forth to break apart any remaining clog, and then I would flush it again. If this does not work, then we would go back and, sorry, I have a typo, not step 12, step 10. So that's something, again, that worked every time for our patients. So definitely something that I would try if you've had issues with this. When it comes to modulars through a feeding tube, there's different recommendations on how much water to use, or some physicians don't even want you to put any modulars through their patient's feeding tube because of risk of clog. But these are the different recommendations that work for these different types of supplements. So for fiber supplements, you should mix with at least 120 milliliters of warm water, and then administer via syringe immediately after mixing. And then you want to flush with 30 milliliters of water before and after administration too. And then, so for the J tube though, it is recommended to kind of divide this in half. So mix half the packet with 120 milliliters of warm water, and then do the same thing with the other half of the packet. And again, flushing with 30 milliliters before and after as well. For a protein modular powder, you want to mix with 60 milliliters of water, and then again flushing with 30 milliliters before and after. And then say you have a gelatinous protein supplement, you dilute 1 ounce of the protein supplement with 1 ounce of water and administer that way. Same thing with the liquid protein supplement, 30 to 60 ml is fine. Mix well and then flush with 30 to 60 ml before and after. Dislodgement is also something that can happen, especially if your patient loses a lot of weight or anything after surgery and after they've had the tube placed. So the first thing you should do if the patient says my tube's kind of coming out a little bit or feels a little bit like it's moving, then if they have a balloon there, you want to make sure that that balloon is inflated. So the best way to do that is to get a saline syringe and then ask them to, or in clinic, we tended to do this over the phone sometimes, but in clinic you can use a saline and push it through the balloon. It's labeled BAL on the feeding tube, and insert that in, and then if you meet resistance, it's full. If you can inject the saline into it, that means that it needs to be inflated. And so this happened a lot with our patients. Sometimes they would end up being able to put in a full 2 syringes of the saline into the balloon because it was that inflated. So a lot of times that will resolve it. If the tube is completely removed and the tract has matured, so usually after about 4 to 6 weeks, a replacement tube can be replaced into that site. So a lot of times doctors will actually use a Foley in that site to just kind of hold it in place and to keep the hole open. But if it's matured, it's not going to close nearly as quickly as if a patient just had their tube placed and then it fell out. So if a tube's completely removed and the tract is not mature, then the tube should not be replaced blindly because the gastric and abdominal walls could have separated and it could cause the tube to be placed into the peritoneal cavity. So removal of feeding tubes. The method of removal definitely depends on the type of tube, obviously. So for NG tubes and Dopphoff tubes, they are removed at the bedside. You want to first, I didn't even include this on here, but you definitely want to remove the thing that's holding it in place. So say they have a bridle or something, they have actually like a guitar pick looking thing that can remove the bridle, or you can use a pair of scissors, doesn't matter. But just make sure you clip that first. Always have the patient take a couple deep breaths if they get really nervous when you tell them that you're removing their feeding tube. It doesn't hurt, it just feels weird. And so I'll have them take a couple deep breaths. We talk about how it's not bad and it's gonna be over in less than a minute. Have Kleenex ready for them because they're gonna want to blow their nose. And then of course, I did include it, be sure to cut the sutures and stuff. And then after it is removed, so you want to slowly remove it. After it's removed, you want to make sure that the end tip is still connected to the tube that you just removed. And sometimes it may feel like the tube is almost like stuck on something, which sounds weird. So there have been times where that end tip has gotten stuck inside. So you always want to check to make sure that's still there. Removal of gastric tubes, obviously a little different. It can be removed when the stoma is mature, so usually 4 to 6 weeks. Our protocol was 6 weeks. If a tube is kept in place by the balloon, then you use a syringe to remove the water or the saline from the balloon. And then if the tube's kept in place by a bumper, the physician will actually pull the bumper through the incision, and it almost sounds like a popping sound when it comes out, which is kind of weird and kind of scares the patient a little bit. So the balloon one's a little bit less traumatic. And then keep the site covered until the tract is closed. Usually it's 24 to 72 hours after removal. I've had patients who've had their feeding tubes removed and 2 weeks later, they're still having some drainage from it. So if that's the case, then, or if it's someone who's had their tube in for a while, you definitely want to monitor that. And then I always tell my patients to avoid eating a large meal right before having their G-tube removed, because we have seen like gastric contents come out right afterwards. Like one patient had pancakes and eggs right before, and then we saw pancakes and eggs come out of the feeding tube site. So not pretty. So Now for the learning assessment. So what is the minimum amount of water that should be used to flush a feeding tube for toothpaste? Good job, 30. True or false? You should avoid gastric residual checks, so stomach acid may cause protein in the tube feeding formulas to precipitate in the lumen of a feeding tube. Yes. And then how long should a PEG tube stay in place before it can safely be removed? Great job. All right, here's the references. And I thought this was funny.